Venous and Lymphatic Drainage, Segmental Innervation, and Comparison of Lower End. Introduction. Venous drainage acquires importance as blood has to flow up against the gravity. The saphenous veins can be easily seen in the leg. The varicose veins, if occur, look quite ugly under the skin. Effort should be made not to develop the varicose veins. The lymph travels mostly to the inguinal group of lymph nodes. The sensory nerves are derived only from ventral rami of L1 to L5 and S1 to S3 segments of spinal cord. Lower limb bud rotates medially, so that extensor compartment lies on front, while flexor compartment is present on the back of thigh. Tibia and big toe lie along the pre-axial border while fibula and little toe are along the post-axial border of the lumb. Venous drainage. Consideration of the venous drainage is of great importance because in the lower limb venous blood has to ascend against gravity. This is aided by a number of local factors, the failure of which gives rise to varicose veins. Factors helping venous return. General factors: 1. Negative intrathoracic pressure, which is made more negative during inspiration. 2. Arterial pressure and overflow from the capillary bed. 3. Compression of veins accompanying arteries by arterial pulsation, and 4. The presence of valves, which support and divide the long column of blood into shorter columns. These also maintain a unidirectional flow. Tocal factors. These are venous, muscular, and facial. 1. Serious: the veins of the lower limb are more muscular than the veins of any other part of the body. They have greater number of valves. Superficial veins are connected to deep veins by perforators. 2. Muscular: when the limb is active, muscular contraction compresses the deep veins and drives the blood in them upwards. It is helped by the suction action of the diaphragm. 3. Facial: the tight sleeve of deep fascia makes muscular compression of the veins much more effective by limiting outward bulging of the muscles. Veins of lower limb. The veins may be classified into 3 groups: superficial, deep, and perforating. Superficial veins. They include the great and small saphenous veins, and their tributaries. They lie in the superficial fascia, on the surface of deep fascia. They are thick-walled because of the presence of smooth muscle and some fibrous and elastic tissues in their walls. Valves are more numerous in the distal parts of these veins than in their proximal parts. A large proportion of their blood is drained into the deep veins through the perforating veins. Deep veins. These are the medial plantar, lateral plantar, dorsalis pedis, anterior and posterior tibial, peroneal, popliteal, and femoral veins, and their tributaries. They accompany the arteries, and are supported by powerful surrounding muscles. The valves are more numerous in upper limbs, deep veins than in superficial veins. They are more efficient channels than the superficial veins because of the driving force of muscular contraction. Perforating veins. They connect the superficial with the deep veins. Their valves permit only one-way flow of blood, from the superficial to the deep veins. There are about 5 perforators along the great saphenous vein, and 1 perforator along the small saphenous vein. The relevant details of these veins are given below. Long saphenous veins. 1. The dorsal venous arch lies on the dorsum of the foot over the proximal parts of the metatarsal bones. It receives 4 dorsal metatarsal veins, each of which is formed by the union of 2 dorsal digital veins. 2. The great or long saphenous vein is formed by the union of the medial end of dorsal venous arch with the medial marginal vein which drains the medial side of great toe. It passes upwards in front of the medial malleolus, crosses the lower 1/3 of the medial surface of tibia obliquely, and runs along its medial border to reach the back o1 the knee. The saphenous nerve runs in front of the great saphenous vein. 3. In the thigh, it inclines forwards to reach the saphenous opening where it pierces the cribriform fascia and opens into the femoral vein. Before piercing the cribriform fascia, it receives 3 named tributaries corresponding to the 3 cutaneous arteries, and also many unnamed tributaries. It contains about 10 to 15 valves which prevent backflow of the venous blood, which tends to occur because of gravity. 1 valve is always present at the saphenofemoral junction. Incompetence of these valves makes the vein dilated and tortuous, leading to varicose veins. The vein is also connected to the deep veins of the limb by perforating veins. There are 3 medial perforators just above the ankle, 1 perforator just below the knee, and another one in the region of the adductor canal, Fig 11.2. The perforating veins are also provided with valves which permit flow of blood only from the superficial to the deep veins. Failure of the valves also gives rise to varicose veins. Tributaries. At the commencement, medial marginal vein from the sole. In the leg, it communicates freely with the small saphenous vein and with deep veins, one just below the knee. 1th anterior vein of the leg run upward forward and medially from the lateral side of thr ankle. 2. The posterior arch vein is large and constant. It begins from a series of small venous arches which connect the medial ankle perforators, and runs upwards to join the great saphenous vein just below the knee. 3. A vein from the calf. This vein also communicates with the small saphenous vein. In the thigh. 1. The accessory saphenous vein drains the posteromedial side of the thigh. 2. The anterior cutaneous vein of the thigh drains the lower part of the front of the thigh, just before piercing the cribriform fascia. Superficial epigastric. Superficial circumflex max. Superficial external pudendal just before termination, deep external pudendal vein. The thoracoepigastric vein runs along the anterolateral wall of the trunk. It connects the superficial epigastric vein with the lateral thoracic vein. Thus it is an important connection between the veins of the upper and lower limbs. Small or short saphenous vein. The vein is formed on the dorsum of the foot by the union of the lateral end of the dorsal venous arch with the lateral marginal vein, see Fig 9.1. It enters the back of the leg by passing behind the lateral malleolus. In the leg, it ascends lateral to the tendocalcaneus, and then along the middle line of the calf, to the lower part of the popliteal fossa. Here it pierces the deep fascia and opens into the popliteal vein. It drains the lateral border of the foot, the heel, and the back of the leg. It is connected with the great saphenous and with the deep veins, and is accompanied by the sural nerve. Perforating veins. As already mentioned, they connect the superficial with the deep veins. These are classified as follows. Indirect perforating veins. Indirect perforating veins connect the superficial veins with the deep veins through the muscular veins. Direct perforating veins. Direct perforating veins connect the superficial veins directly with the deep veins. The great and small saphenous veins are the large direct perforators. The small direct perforating veins are follows: 2 below the knee. 1 perforator connects the great saphenous vein or the posterior arch vein with the posterior tibial vein. 3 in the leg, a lateral perforator is present at the junction of the middle and lower thirds of the leg. It connects the small saphenous vein, or one of its tributaries, with the peroneal vein. Medially there are 3 perforators which connect the posterior arch vein with the posterior tibial vein. The upper medial perforator lies at the junction of the middle and lower thirds of the leg. The middle medial perforator lies above the medial malleolus. Malleolus. The lower medial perforator lies postero-inferior to the medial malleolus. Clinical anatomy: calf pump and peripheral heart. In the upright position of the body, the venous return from the lower limb depends largely on the contraction of calf muscles. These muscles are, therefore, known as the calf pump. For the same reason the soleus is called the peripheral heart, see Fig 9.3. When this muscle contracts, blood contained in large sinuses within it is pumped into the deep veins, and when the muscle relaxes, blood flows into the sinuses from the superficial veins. Unidirectional blood flow is maintained by the valves in the perforating veins, Fig 11.6. Cut open procedure / venesection is done on the great saphenous vein as it lies in front of medial malleolus. This vein is used for transfusion of blood flow in case of non-availability or collapse of other veins. Saphenous nerve is identified and not injured as it lies anterior to the great saphenous vein, Fig 11.7. Great saphenous vein is used for bypassing the blocked coronary arteries. The vein is reversed so that valves do not block the passage of blood. Varicose veins and ulcers: if the valves in perforating veins or at the termination of superficial veins become incompetent, the defective veins become high-pressure leaks through which the pressure of the deep veins produced. Features: long saphenous vein. Beginning and medial end of dorsal venous plexus. Position anterior to medial malleolus. Number of 15-20 valves. Relation of a saphenous nerve sensory nerve. Termination. Femoral vein. Lymphatic drainage. Short saphenous vein. Lateral end of dorsal venous plexus posterior to lateral malleolus 8-10 valve sural nerve popliteal vein. Muscular contraction is transmitted to the superficial veins. This results in dilatation of the superficial veins and to gradual degeneration of their walls, producing varicose veins and varicose ulcers. Varicose veins often occur during third trimester of pregnancy, as the iliac vein get pressed due to enlarged uterus. These mostly subside after delivery. Trendelenburg's facel, this is done to find out the site of leak or defect in a patient with varicose veins. Only the superficial veins and the perforating veins can be tested, not the deep veins. The patient is made to lie down, and the veins are emptied by raising the limb and stroking the varicose veins in a proximal direction. Now pressure is applied with the thumb at the saphenofemoral junction and the patient is asked to stand up quickly. To test the superficial veins, the pressure is released. Quick filling of the varicose veins from above indicates incompetency of the superficial veins. To test the perforating veins, the pressure at the saphenofemoral junction is not released, but maintained for about a minute. Gradual filling of the varices indicates incompetency of the perforating veins, allowing the blood to pass from deep to superficial veins. After a deep vein thrombosis affecting the perforators, they recanalize without valves. So the muscle pump will force blood from deep to superficial veins, causing varicosity of the veins. Varicose veins are treated with sclerosing injections or laser treatment. Lymphatic drainage. Most of the lymph from the lower limb drains into the inguinal lymph nodes, either mostly directly or partly indirectly through the popliteal and anterior tibial nodes. The deep structures of the gluteal reglone and the upper part of the back of the thigh drain into the internal iliac nodes along the gluteal vessels classification. Lymph nodes. Superficial inguinal lymph nodes. Deep inguinal lymph node. Popliteal lymph node. Anterior tibial lymph node. 2 lymphatic, superficial and deep. Superficial inguinal lymph nodes. These are very important because they drain the skin and fasciae of the lower limb, the perineum and the trunk below the umbilical plane, see Fig 3.5. They are divided into 3 sets. 1. The lower vertical group is placed along both sides of the terminal part of the great saphenous vein, and contains about 4 or 5 nodes. They drain the skin and fasciae of the lower limb, great saphenous territory, except the buttock and the short saphenous territory. A few lymphatics, accompanying the short saphenous vein, cross the leg, accompany the great saphenous vein, and drain into this group of nodes. 2. The lateral group is placed below the lateral part of the inguinal ligament, and contains about 2 or 3 nodes. They drain the skin and fasciae of the upper part of the lateral side of the thigh, the buttock, the flank, and the back below the umbilical plane. 3. The upper medial group is placed below the medial end of the inguinal ligament. 1 or 2 nodes may lie above the inguinal ligament along the course of the superficial epigastric vessels. The group contains 2 to 3 nodes. They drain, a. the anterior abdominal wall below the level of the umbilicus. The perineum, including extemal genitalia, except the glands, the anal canal below the pectinate line, the vagina below hymen and the penile part of the male urethra. D. Superior-lateral angle of the uterus via thr round ligament. C. Efferents from all superficial inguinal nodes pierce the cribriform fascia, and terminal in the deep inguinal nodes. A few may pass directly to the extemal iliac nodes. Deep inguinal lymph nodes. These are about 4 to 5 in number, and lie medial to the upper part of the femoral vein. The most proximal node of this group, gland of Cloquet or of Rosenmuller, lies in the femoral canal. These nodes receive afferents from the superficial inguinal lymph node. The popliteal nodes. Gland penis or clitoris. The deep lymphatics of the lower limb accompanying the femoral vessels. Their efferents pass to the external iliac lymph node. Popliteal Iymph nodes. These nodes lie near the termination of the small saphenous vein, deep to the deep fascia. One node lies between the popliteal artery and the oblique popliteal ligament. They receive afferents from, 1. The territory of the small saphenous vein. 2. The deep parts of the leg, through vessels running along the anterior and posterior tibial vessels. 3. The knee joint. Their efferents run along the popliteal and femoral vessels, and terminate in the deep inguinal nodes. Anterior phi-6 Iymph node. One inconstant node may 1 ie along the upper part of the anterior tibial artery. When present, it collects lymph from the anterior compartment of the leg, and passes it on to the popliteal nodes. Superficial L/lymphatics. These lymph vessels are larger and are more numerous than the deep lymphatics. They run in the superficial fascia and ultimately form two streams. The main stream follows the great saphenous vein, and ends in the lower vertical group of superficial inguinal lymph nodes shown in Fig 11.9a. The accessory stream follows the small saphenous vein and ends in the popliteal lymph nodes, Fig 11.9b. Deep lymphatic. These are smaller and fewer than the superficial lymphatics, although they drain all structures lying deep to the deep fascia. They run along the principal blood vessels, and terminate mostly into the deep inguinal nodes, either directly or indirectly through the popliteal nodes. The deep lymphatics from the gluteal region and from the upper part of the back of the thigh accompany the gluteal vessels and end in the internal iliac nodes. Elephantiasis, lymphatic obstruction caused by the parasite filaria, is very common in the lower limb. This results in great hypertrophy of the skin and of subcutaneous tissue, elephantiasis, Fig 11.10. The commonest cause of a swelling in the inguinal area is enlargement of the inguinal lymph nodes. This can be caused by infection, or carcinoma, anywhere in the area drained by these nodes, Fig 11.11. Segmental innervation. Dermatomes. The principles involved are the same as described in the upper limb. The area of skin supplied by one spinal segment is called a dermatome. Important features. 1. The cutaneous innervation of the lower limb is derived, mainly from segments L1 to L5 and S1 to S3 of the spinal cord, and partly from segments T12 and S4. As a rule, the limb is supplied only by anterior primary rami. The exception to this rule is that the two skin of the superomedial quadrant of the gluteal region is supplied by the posterior primary rami of nerves L1 to L3 and S1 to S3. 3. There is varying degree of overlap of adjoining dermatomes, so that the area of sensory loss following damage to the spinal cord or nerve roots is always less than the actual area of the dermatome. 4. Initially, each limb bud has a cephalic border, and a caudal border. These are known as the pre-axial and the post-axial borders, respectively. In the embryo, the great toe and tibia lie along the pre-axial border, and the little toe and fibula along the post-axial border. Later, the limb bud rotates medially through 90 degrees, so that the great toe and tibia are carried medially, and the little toe and fibula laterally. Thus, the tibial border is the original pre-axial border, and the fibular border, the post-axial border, of the lower limb. 5. The dermatomes of the lower limb are distributed in an orderly numerical sequence, Figs 11.12a and b. Along the pre-axial border from above downward there are dermatomes. The medial 3 yo's the adjoining area of dorsum of the foot and the lateral side of the leg supplied by segment L5. 6. Along the post-axial border from below upwards there are dermatomes S1, S2, S3. 7. As the limb elongates, the central dermatomes, L4, L5, S1, get pulled in such a way that these are represented only in the distal part of the limb, and are buried proximally. The line along which the central dermatomes are buried is known as the axial line. In fact, an axial line is defined as a line along which certain dermatomes are buried, missing, so that distant dermatomes adjoin each other. Overlapping of the dermatomes is minimal across the axial line. There are two axial lines, one ventral and one dorsal, both of which extend largely on the back of the limb. On the posterior surface of the limb, the central axial line extends up to the heel, whereas the dorsal carotid line ends at a higher level, at the junction of the upper 2/3 and lower 1/3 of the leg. On the anterior surface of the limb, the ventral axial line crosses the scrotum, and the dorsal axial line encroaches on the lateral side of the knee. Some workers deny the existence of the dorsal axial line. Myotomes. A spinal nerve supplies muscles that are derived from one myotome. Most of the muscles are supplied by more than one segment of the spinal cord, the supply by some segments being predominant. Damage of the predominant segments results in maximum paralysis of the muscle. The chart given below is accurate enough for use in clinical examination. L1 POAS major. L2 psoas major, iliacus, sartorius, gracilis, pectineus, adductor longus, adductor brevis. L3 quadriceps, adductors, longus, brevis, magnus. Quadriceps, tensor fasciae lati, adductor magnus, obturator externus, tibialis anterior, tibialis posterior. L5 gluteus medius, gluteus minimus, obturator interns, semimembranosus, semitendinosus, extensor hallucis longus, extensor digitorum longus, peroneus tertius, popliteus. S1 gluteus maximus, obturator intimus, piriformis, biceps femoris, semitendinosus, popliteus, gastrocnemius, soleus, peronei, extensor digitorum brevis. S2 piriformis, biceps femoris, gastrocnemius, soleus, flexor digitorum longus, flexor hallucis longus, intrinsic muscles of foot. S3 intrinsic muscles of foot, except abductor hallucis, flexor hallucis brevis, flexor digitorum brevis, extensor digitorum brevis. 6 joint movements. The segmental innervation of muscles can also be expressed in terms of movements of joints. Like dermatomes, the myotomes are also helpful in determination of the level of a lesion in the spinal cord. Sympathetic innervation. One sympathetic innervation of the lower limb is derived from the lower 3 thoracic and upper 2 lumbar, T10 to L2, segments of the spinal cord. The fibers arise from the lateral horn cells, and pass out with the ventral roots as preganglionic, white rami, fibers. These pass down the sympathetic chain to relay in the lumbar and upper 2 or 3 sacral ganglia. 2. The postganglionic fibers emerge from the lumbar sympathetic ganglia and pass through gray rami to reach the lumbar nerves. From these nerves they pass into the femoral nerve. They supply the femoral artery and its branches in the thigh. Some postganglionic sympathetic fibers emerge from the upper 2 or 3 sacral ganglia. They travel through the tibial nerve to supply the popliteal artery and its branches in the leg and foot. 3. The blood vessels to skeletal muscles are dilated by sympathetic activity. These nerves are vasomotor, pseudomotor and pilomotor to the skin. 4. Sympathetic denervation of the lower limb can be produced by removing the 2nd, 3rd, and 4th lumbar ganglia with the intermediate chain. This divides all preganglionic fibers to the lower limb. The first lumbar ganglion is preserved because it controls the proximal urethral sphincter mechanism. Its removal is followed by dry coitus. Bilateral lumbar sympathectomy is done in patients with Berger's disease. Mnemonics: Crete Saphenous vein MMMM. M. Medial end of dorsal venous arch. Medial marginal vein ends into it. M. Lies anterior to the medial malleolus. M. Crosses medial surface of tibia obliquely. M. Runs behind medial border of tibia to reach behind the knee. M. Runs along medial side of thigh to end in the saphenous opening. Long saphenous vein with saphenous nerve lie anterior to medial malleolus. Short saphenous vein lies behind lateral malleolus. Varicose veins are due to tortuosity of the long saphenous vein and occur mostly due to prolonged standing. Long saphenous vein is used to bypass the coronary artery after inverting the vein.